Hi, my name is Katayan Fethat. I am a fourth year medical student. I will be presenting interview with a psychiatrist, clinical perspectives on obsessive compulsive disorder. This presentation was written by Dr. Jonathan Terry, who is a board certified psychiatrist. As a fourth year medical student who matched into psychiatry, I have experience rotating in different areas of psychiatry like consult liaison, inpatient as well as outpatient. Throughout my time at my medical school, I've worked very closely with Dr. Terry and have shadowed him as well. So let's get started. A clinical definition of OCD. OCD is a chronic and disabling mental health condition characterized by the presence of obsessions, intrusive unwanted thoughts, images, or urges, and compulsions, repetitive behaviors or mental acts performed to reduce the distress caused by obsessions. According to the DSM-5, to qualify for a diagnosis of OCD, the obsessions or compulsions must be time-consuming, so take more than an hour per day. They must cause significant distress or impairment in social, occupational, or other important areas of functioning, and cannot be better explained by another mental disorder or the effects of a substance. Neurobiologically, OCD is associated with dysregulation in the corticostriatal-thalamocortical, or CSTC for short, circuits. Serotonergic dysregulation is implicated, which explains the utility of SSRIs in treatment. Contributing factors to OCD. There is no single cause of OCD. Rather, it's the result of a combination of genetic, neurobiological, cognitive, and environmental factors. Genetics. Family studies suggest a heritability estimate of 27 to 65%. Neurobiology. Functional imaging shows increased activity in the orbitofrontal cortex, anterior cingulate cortex, and caudate nucleus. Cognitive distortions. Maladaptive beliefs such as inflated responsibility, thought-action fusion, and perfectionism are common. Environmental factors. Stressful life events or trauma may precipitate or exacerbate symptoms. In children, autoimmune-related OCD, or PANDAS, has been linked to streptococcal infections. So let's go through a patient case. This is a 28-year-old female client, let's call her client A, who presented with contamination obsessions and washing compulsions. Her symptoms started in adolescence, but escalated in her late 20s after a breakup and work-related stress. She washed her hands for up to 3 hours daily and avoided public spaces due to fear of germs. Let's go through the symptoms and functional impact. So client A experienced obsessions, which were persistent intrusive fears of contamination from door handles, shared surfaces, and food. She also displayed compulsions, which were excessive hand washing, avoidance of public places, repetitive cleaning of her apartment. These symptoms led to absenteeism at work, difficulty maintaining friendships, and significant strain on family relationships. She avoided handshakes and required extensive reassurance from loved ones. Little patient history. Client A reported being a perfectionistic and anxious child. Her father had a history of generalized anxiety disorder. She denied any major trauma but recalled excessive emphasis on cleanliness during her upbringing. She was high achieving academically but prone to self-doubt and over-responsibility. So how did we treat her? So, treatment plan was multimodal with cognitive behavioral therapy with exposure and response prevention, ERP, as the cornerstone intervention. This involved gradually exposing her to fearful stimuli, such as touching door handles, without engaging in compulsive washing. Pharmacotherapy. She was started on fluoxetine, which is an SSRI, titrated to 60 milligrams daily. SSRIs are FDA approved for OCD and are considered first-line pharmacologic treatment. Psychoeducation and self-monitoring strategies were incorporated. Some of the treatment challenges for patients with OCD include poor insight. Many patients underestimate the irrationality of their compulsions. Avoidance. Patients may avoid therapy exercises due to discomfort with exposure. Treatment resistance. About 40 to 60% of patients may have only partial response to first-line SSRI treatment. To address these, Dr. Terry uses motivational interviewing. He collaborates closely with patients to build trust and involve family members to reinforce ERP techniques at home. Augmentation with low-dose antipsychotics such as risperidone can be considered in SSRI-resistant cases. Treatment outcomes. So, client A showed marked improvement after 16 weeks. She reduced hand washing to within normal limits and resumed working full-time. She reported greater confidence and reduced anxiety in social situations. Periodic booster sessions were scheduled to prevent relapse. A note on professional boundaries. Setting boundaries is critical, particularly because clients with OCD may seek reassurance frequently or attempt to engage the provider in compulsive rituals. So, like asking if a surface is clean. Dr. Terry maintains clear session structure, limits on reassurance while validating emotional distress, written treatment contracts outlining the goals and roles of therapy, supervision, and consultation to monitor for countertransference. Building the therapeutic alliance. Key strategies include empathetic listening and normalizing the experience of intrusive thoughts. Transparency about the treatment process and rationale for ERP, collaborative goal setting, validation of distress without reinforcing compulsive behavior. Research shows that a strong therapeutic alliance is a predictor of positive outcomes in CBT for OCD. Now, common misconceptions about OCD. One major myth is that OCD is simply about liking things neat and organized. In reality, OCD can be debilitating and is not synonymous with being tidy or perfectionistic. People with OCD often experience severe anxiety and perform compulsions to reduce distress, not for enjoyment. Public awareness can be improved through mental health literacy campaigns, testimonials from those with lived experience, school-based education on anxiety disorders. The role of trauma and ACEs. Trauma is not a primary cause of OCD, but adverse childhood experiences can be contributed to vulnerability. For some individuals, trauma may exacerbate pre-existing anxiety or perfectionistic tendencies or contribute to specific obsessional themes such as safety and control. Some studies suggest that individuals with OCD and a trauma history may have poorer insight and more severe clinical course. In such cases, trauma-informed care and possibly integration of trauma-focused therapy may be beneficial. Family involvement is also important in the treatment plan. Dr. Terry educates family members on not accommodating compulsion, so avoiding reassurance, not helping with rituals. And the use of family-based CBT can improve outcomes in youth and adults. Involving partners or parents can help with monitoring exposure tasks, reinforcing gains, and preventing relapse. We also address family stress and burnout, as caring for someone with OCD can be emotionally taxing. On this last slide are the references Dr. Terry used to put this presentation together. So thank you for your attention, and I hope you enjoyed.